Welcome to this explainer. Today, we're taking a deep, enthusiastic dive into the incredibly complex world of epilepsy. We are going to unpack this fascinating condition, starting all the way down from a microscopic spark inside a single brain cell, and then we'll zoom all the way out to those high-stakes clinical interventions that happen in the emergency room. You know, seizures actually affect roughly 5 to 10% of the population at some point in their lives, so getting a solid grasp on the mechanics of this condition is absolutely crucial.
Okay, let's jump right in. Here is our roadmap for today. 1. Cellular origins. 2. Genetic channelopathies. 3. Focal versus generalized seizures. 4. Mesial temporal lobe epilepsy. And finally, 5. Status epilepticus and pharmacology.
Section 1. Cellular origins of seizures. The microscopic spark. So, at the cellular level, the microscopic spark that actually ignites a seizure is this phenomenon called the paroxysmal depolarization shift. Picture this, an intense, near-simultaneous firing of a bunch of local excitatory neurons. Instead of your normal, beautifully regulated communication, you get this relatively long-lasting depolarization of the neuronal membrane. This effectively hypersynchronizes an entire region of the cortex. It's the absolute hallmark of an established seizure, and it's what ultimately produces that classic electrographic spike we look for on brain monitors. Now, this microscopic spark rapidly builds into a fierce biochemical cascade. First off, we have an influx of extracellular calcium flooding into the neuron. This depolarization triggers the opening of voltage-dependent sodium channels. And once those sodium channels pop open and sodium rushes in, boom, it generates repetitive action potentials, just rapid-fire electrical bursting. Finally, the cell desperately attempts to halt those chaos with a hyperpolarizing afterpotential that's mediated either by GABA receptors or potassium channels, depending on the specific cell type. It's all about this delicate balance of excitation and inhibition, and during a seizure, that balance is just violently disrupted. Moving right along to Section 2, genetic channelopathies, the faulty blueprint. When the genetic blueprint for these ion channels we just talked about is flawed, the brain's threshold for seizures drops dramatically. In fact, many inherited epilepsies are essentially channelopathies, which are disorders of those specific ion channels. For instance, take a look at the SCN1A gene. A mutation here disrupts a voltage-gated sodium channel, and that leads directly to Dravet syndrome, which is a really severe myoclonic epilepsy in infants. Then we have KCNQ2. This affects potassium channels, impairing the cell's ability to repolarize, and it's strongly linked to familial neonatal epilepsy. And CHRNA4, that alters calcium flux through a nicotinic acetylcholine receptor, causing sleep-related hypermotor epilepsy. So these aren't just abstract genetic concepts, right? They are faulty blueprints that directly cause these real-world electrical storms. Section 3. Focal versus generalized seizures. Brain network classifications.
Zooming out a bit to the macroscopic brain networks, we have to ask, how do these storms actually spread? Well, focal seizures originate in a localized neuronal network within just one cerebral hemisphere. So a patient might have twitching in just one hand, or they might experience a subjective aura, like a strange smell or a sudden feeling of déjà vu, and their awareness might be completely intact or partially impaired. On the flip side, generalized seizures arise and rapidly engage networks distributed across both cerebral hemispheres simultaneously. There is no localized starting point that we can observe. It's just a sudden, massive, brain-wide event.
And if you look at an EEG, a generalized seizure looks exactly like an electrical tidal wave. Notice how those rhythmic, repetitive waves appear on all the lines at the exact same time? This is classic 3 Hz spike wave activity, occurring synchronously over both hemispheres during an absent seizure. You can literally see this intense synchronized firing sweeping across the entire brain at once, which perfectly correlates with those sudden, brief lapses of consciousness these patients experience. Section 4. Mesial temporal lobe epilepsy, a structural reality. Now, let's focus on the most common syndrome involving focal seizures, which brings us straight to the hippocampus. Look really closely at the arrow on this high-resolution MRI. We're looking at a coronal view of the brain here, and that arrow is pointing to a noticeably small left hippocampus that has an abnormal high signal intensity. This is the absolute hallmark of hippocampal sclerosis. It's a shrunken, damaged structure that essentially serves as the physical epicenter for chronic focal seizures. For so many patients, this structural change is the fundamental physical reality driving the pathophysiology of their epilepsy. And the reason the structural damage matters so deeply is that it wipes out crucial inhibitory neurons, specifically within a region called the dentate gyrus. Think about it. When you lose these specific neurons, it's essentially like totally removing the brakes from the brain. The surviving neurons try to compensate by reorganizing their networks, but that just leads to local hyperexcitability running rampant. The brain basically transforms into an environment that is chronically, persistently susceptible to generating seizures. Section 5, Status Epilepticus and Pharmacology, the clinical emergency. But what happens when the storm simply won't stop? Notice the strict urgency here. Practically speaking, at just 5 minutes of continuous generalized convulsive seizure activity, we are in a massive medical emergency. If the seizure enters that 5 to 30-minute window, it's considered impending or early status epilepticus. At this stage, things like cardiorespiratory dysfunction, hyperthermia, and metabolic derangements become huge, life-threatening issues. If it pushes past 30 minutes, it's established, and if it somehow rages past 48 hours, it becomes late refractory. As the clock ticks through these critical phases, our pharmacology has to escalate aggressively. In the early phase, our first line of defense is fast-acting intravenous benzodiazepines, things like lorazepam or midazolam. If the storm pushes into the established phase, we hit it with heavy-hitting IV anti-seizure drugs, phenytoin, valproic acid, or levetiracetam. And if it crosses into that terrifying late refractory phase past 48 hours, well, at that point, the only way to protect the brain is by ultimately resorting to profound anesthetic comas using continuous drips of propofol or pentobarbital. It is, quite literally, an all-out pharmacological war to stop the electrical storm. To wrap up this explainer, I want to leave you with a rather provocative thought. What is really the ultimate frontier in neuroscience right now? You see, currently, all those drugs we just discussed, they are anti-seizure. They suppress the active electrical storm. But we currently have absolutely no drugs that are anti-epileptogenic. What that means is, if someone suffers a severe head trauma or a stroke or a severe infection in the central nervous system, we have no medication today that can prevent their normal neuronal network from transforming into an epileptic one months or even years down the line. Figuring out how to halt that tragic transformation, how to stop the brain from ever learning how to seize in the first place, that is the next great leap forward. Thank you so much for joining me on this deep dive. I really hope this leaves you with a profound appreciation for just how incredibly complex the human brain truly is.